Hello, future nurses. This is Professor Flourish. Today we are going to be talking about immunity. So before we get in, I want to talk about the different types of basic immunity. You have innate and adaptive. The target of the immune system is antigens, which are these non-self substances. Now with this, something that you want to keep in mind is that not everyone's immune system is the same, regardless of their age. Everyone has different ways that they fight things and we'll talk about that more when we get into our adaptive immunity. So like I said, everyone's immune system is different. So your innate immunity. The innate immune mechanisms comes to the defense of the body first and immediately. So innate is what we're all just born with. It's composed of natural anatomical barriers, normal flora, white blood cells. So basically things like your macrophages will phagocytose foreign debris and antigens, protective enzymes and chemicals, things like your hydrochloric acid in your stomach, interferon, cytokines. All of these are the innate immunity. So like I said, unless you had a defect at birth, these are the things that you're born with. It's things like we have skin as our outer layer, all things that help fight whatever comes at us. Then you have adaptive immunity. So adaptive immunity comes to the body's defense after the innate system. So these are different. This is what makes us each unique. And this is why some people will develop pneumonia. Some people will be able to have had pneumonia and develop a immune response to that. It's a more specific form of protection. It's developed after exposure to antigen. So like I said, using that pneumonia kind of example, the first time you face it, your body has a response. And then after that, it develops these antibodies, which we'll talk about more when we continue. It acts rapidly, specifically, and destructively, and with memory for every individual antigen it has encountered. Major histocompatibility complexes. So these are the surface antigens on every human cell. So when we talked about our tissue lecture about donating organs, that's what we were talking about, are these histocompatibility complexes. This allows the adaptive immunity to distinguish between host and invader. And then this is just a zoom in of that picture that I had. You've got innate versus adaptive immunity. See, the adaptive, we've got our B and T cells, which we'll talk about more when we continue on. Innate, we've got all these other kind of white blood cells. You've got things like your neutrophils, eosinophils, basophils, macrophages, all these kind of just ones here. So in our adaptive immunity, we've got two major categories. You've got B lymphocyte immunity, also known as hormonal immunity or B cell immunity. And you've got T lymphocyte immunity, also known as cell-mediated immunity or T cell immunity. So T cell immunity is the one we're going to talk about first. This is cell-mediated immunity. So T cells cannot be activated by antigen alone. So you've got antigen-presenting cells or dendrite cells. CD4 cells are your helper cells, influences all other cells of the immune system, including other T cells, B lymphocytes, macrophages, and your natural killer cells, and they release T cell cytokines. So these CD4 cells or the CD4 cells or your T helper cells are the ones that are influencing everything else in the immune system. So if we have a disorder such as HIV that attacks this, then we're essentially attacking all these other immune system responses. You've got your CD8 cells, which are your cytotoxic T cells, which directly attacks an antigen. So on here, the way your T cell immunity works is you've got the antigen here, and then step one, antigen stimulates APC, which is your antigen presenting cell, also called a dendrite cell. Step two, antigen is being processed by the antigen presenting cell. Step three, cytotoxic T cell attacks antigen, APC complex, complement pro-inflammatory proteins assist in immune response. And then step 4, helper T cells assist in the immune response against antigen. Helper T cells release cytokines, pro-inflammatory mediators. So with this one, you have this area here. So you've got an antigen and then a cell that basically responds to said antigen and then releases out and eventually getting these T helper cells. That's why HIV, when we talk about it, is such a dangerous concept, because what it does is it delays what's happening here. So it kind of attaches to these CD4 cells, it hides itself and makes it so they don't realize that it's foreign until it's too late. So like I said, T cells, they have to have this antigen presenting cell. Your B cell immunity is your hormonal immunity. B lymphocytes, also called B cells, are naive or immature until they encounter an antigen. After exposure to an antigen, B cells are stimulated to further mature into plasma cells. As plasma cells, they have the ability to produce specific proteins called immunoglobulins, also called antibodies, which attack the antigen. So with this, your B cells in a healthy functioning B cell is where they recognize antigens, and they basically will attack that antigen. So step 1, antigen stimulates B lymphocyte. B lymphocyte turns into a plasma cell. Plasma cells secretes immunoglobulins that attack antigen, and then helper T cells can assist in this immune reaction. So what happens is, the way I picture it is, you've got all these little B cells that are all kind of hanging out and waiting until something happens. Then when an antigen comes up, they basically change themselves to be attached to that antigen. So that way, anytime you have that antigen again, your body's going to remember it and be able to attack it. This is why if you have something like a common cold, what will happen is you'll have that cold a bunch of times, like 3-4 times a year, and then after a while, you suddenly just can't even remember the last time you had one. And that's because your body recognizes this common cold, this virus of the cold, and it's able to fight it, all because we've got this healthy B cell functioning. So as long as you've got this healthy B cells, then they're able to fight off these different pathogens that come in, and they're able to have memories of what they've encountered previously. This here is just another very helpful video that talks about the different types of immune responses. So the next thing we're going to be talking about is your antibodies. Remember, these are the ones that are created, these immunoglobulins are created with that B cells. So you've got 5 subtypes: immunoglobulin M, immunoglobulin G, immunoglobulin A, immunoglobulin E, and immunoglobulin D. They're responsible for neutralizing bacterial toxins, attacking viruses, promoting phagocytosis, and activating the immune response. So with this is the body's antibody-mediated response to an antigen that consists of 2 phases. So your primary phase is the first time the host is exposed to an antigen. So using that cold one, this is the very first time that I've been introduced to a cold. So with this, it's marked by proliferation of immunoglobulin M, which is the primary immunoglobulin responder and marks the primary response, and it's very large in size. The second immune response is the second exposure to the same antigen, which stimulates a quick increase in levels of immunoglobulin G, immunoglobulins. So the way I remember these ones is M comes first because your mother comes first. So I remember it like M for mom. So immunoglobulins M are the first ones. So those are the first things that show up as that primary phase. So the first time I see a cold, who's going to take care of me? My mom. So immunoglobulins M's. Secondary immune response is the second exposure to the same antigen. So the way I think of this is G for girlfriend. So it's like your mom comes first, and then the second person to take care of you would be your girlfriend. So that's how I think of it. It's the second time the antigen is coming. So the first time you see it, you've got this big release of immunoglobulin M, and then the second exposure to the antigen, you get this big release of immunoglobulin G. So your other immunoglobulins. You've got immunoglobulin A, which is found mainly in the secretions. So those are things like your tears, saliva, nasal, respiratory secretion, GI fluid, and breast milk. So the way I always remember your A's is you're going to cry for an A. So that's how I remember those ones. That's all in that like external secretions. Immunoglobulin E is usually presented in a very low concentration in the blood, but it rises to high levels in allergic reactions. So what do we use when somebody has an anaphylactic shock to something like a bee sting? I'll give you guys a second to think about it. Epinephrine. So the way I remember immunoglobulin E is you're going to give epinephrine. So the ones that you see that are in high levels are your immunoglobulin E. Immunoglobulin D, which binds the basophils and mast cells in hypersensitivity reaction, composes of only 1% of immunoglobulins. So this one, the way I remember it is people get hypersensitive when they make a D. I know it's kind of a silly way to remember these things, but it just makes it a little bit easier when you're trying to think about these. So going through them again, immunoglobulin M, mom comes first, because that's the first person who takes care of you when you're sick. Immunoglobulin G, the second person to take care of you would be your girlfriend. Immunoglobulin, or if you are the girlfriend too. So girlfriend taking care of boyfriend, so on and so forth. Immunoglobulin A, I'm going to cry for my A. Immunoglobulin E, I use epinephrine E for allergic reactions. So you see immunoglobulin E's and allergic reactions. Immunoglobulin D is hypersensitivity. I'm going to be very hypersensitive if I make a D. So there's other ways to remember it. That's just the way that's always kind of made sense with me. Because we first want to know which type of immunoglobulins we're dealing with, and then we can also talk about the different types. So immunity can be active acquired or passively acquired. So active acquired adaptive immunity. So this is obtained through exposure to an antigen or through immunization. So things like a vaccine. Body synthesizes specific immunoglobulins against an antigen. Disease is contracted, immunoglobulins develop, you recover. So that's what happens. Like, for example, if you were exposed to chickenpox as a child, then you develop these antibodies against it, and then you eventually recovered from it. Vaccines basically kick out this middle person here having to recover, or kicks out this disease contracting. So what happens with the vaccine is they basically, people in their science labs basically made it so they're only getting the not the antibodies, they're only getting certain so what basically happens with the vaccine is the genes for the disease are removed. So you give this vaccine and then people can develop these immunoglobulins. Either way, whether you contracted the disease or you were given the vaccine, both of them give you long-term immunity. An immunization is a weakened virus. It cannot cause disease. Basically, all the genes for the disease are removed. When a vaccine is administered, the body thinks it is an antigen. The body then builds up specific immunoglobulins against it. And then sometimes more than one dose is needed. So like for Hep B, you've got 3 different doses for it. Now, every now and again, you might need what's called a booster shot. A booster shot is a repeated vaccine administration sometime after the initial vaccine, and it's given to basically remind the body to make immunoglobulins. It's kind of like what I usually use as an example is, do you remember every single thing you learned in fundamentals? And you can be honest with yourself because you're probably listening to this while you're by yourself. So being really honest with yourself, do I remember exactly what was on exam 2 in fundamentals? No. So that's why when you get to these later dates, or like when we do those HESI reviews and stuff, it's a little reminder. Same thing with these booster shots, is they're little reminders for your body to remember how to fight off whatever antigen it's going against. An example for this would be receiving an MMR booster before you go to college. So passive acquired adaptive immunity is an injection of pre-manufactured immunoglobulins. The body merely passively accepts the immunoglobulins, and the body does not have to manufacture them. So this gives short-term immunity. So this is basically administered when the patient needs immediate immunity now because it's in close contact with the virus. So for example, you can also give it from mother to baby in breast milk. So hepatitis B immunoglobulin and immunoglobulins in breast milk. So when you think about it, the way I think about it is like this. Active acquired adaptive immunity is kind of like I teach the man to fish. So I'm teaching my body how to fish. In this sense, I'm teaching my body how to fight off this antigen. While passive acquired adaptive immunity is I'm handing the man the fish. He's going to be able to eat and he's going to be able to fight off this virus, but he does not have long-term immunity. So that's the big difference, is one gives you long-term, one gives you short-term. The ANGRY panel is a test of immunocompetence, consists of common antigens that individuals are exposed to, things like Candida, mumps, etc. Antigens are injected intradermally, just under the skin. Individuals should have a positive skin reaction to one or more of these antigens, indicating general immunocompetence. No reaction to the skin indicates a lack of immune response and immunodeficiency. So this ANGRY test is basically just trying to see how competent is their immune system. If they don't have a reaction, that means that they're not very competent because they're giving them these antigens that should develop some sort of reaction. The antibody titer or antibody screening test is used to confirm adequate immune protection against a particular antigen by measuring MGMs and MGG immunoglobulins. Remember, we're trying to see the first exposure opposed to the second exposure. Elevated immunoglobulin M levels indicate a recent or current infection. That makes sense because those are the antibodies we see first. Immunoglobulin G levels indicate prior exposure and immune competence to a particular antigen. So these Gs are seeing the second time it's exposed. Then we got to talk about our our allergy test. So we've got different types of allergy tests here. We've got our white blood cell count with differential, our skin test, and our RAS test. Now with our white blood cell count, this will only show if the patient is actively reacting. So this white blood cell count doesn't really do anything for us unless we have somebody who came in with anaphylactic shock. Then we may see certain blood cells that are certain white blood cells that are elevated. So this won't really tell us anything other than actively reacting. The skin tests are the ones that most people do, and this measures the body's reaction to an allergen injected or scratched onto the skin. You've got different types. You've got the prick, the patch, and the intradermal. So with these, what you want to know is what is considered a positive test. So for the prick, it usually results within 15 minutes. However, your thick and old skin can decrease reactivity. So that's the only thing with the prick. And on this next one, I show you on this video here that you can watch on Momentum, it shows you what it looks like with the actual prick. The patch test will result in 1 inch area of erythema, means a positive test. Intradermal is your wheal is larger than 5 centimeters from the control, and erythema, which equals a positive test. So knowing what these positive tests look like, opposed to not being positive. So the last one is the RAS test, which measures the allergen-specific immunoglobulin E antibodies in serum samples after a panel of allergens have been added to samples. So what basically happens is they use the serum samples, they add the panel of allergens, and they see, are they developing this immunoglobulin E? Now, this is very useful for patients who cannot do a skin test. So if they can't do a skin test, you can do this RAS test instead. And it'll be a lot more accurate than just using a white blood cell count, because the white blood cell count isn't going to show it unless they're actively reacting. But this RAS, we can go ahead and see, Okay, are they allergic without actually using a skin test? And this right here, like I said, is just an example of them doing the prick allergy. Up here on here, they have the little bit of histamine because everybody reacts slightly to histamine. And what that will do is see what does their particular skin reaction look like. And they basically just prick in a little bit of the allergens. That way we can see what sort of reactions they have. Okay, so these are our hypersensitivity reactions, damaging immune reactions. So these are things where our immune system is not working appropriately. And yes, you are going to want to know these. You've got your type 1 immediate hypersensitivity, type 2 cytotoxic, type 3 immune complex disorders, and type 4 delayed hypersensitivity. So your type 1 is your hypersensitivity reaction. This is immediate. Mast cells release histamine, and examples include things like hives, nasal, so allergic rhinitis, conjunctival discharge, bronchial asthma, systematic anaphylaxis. Some of your common allergens are things like your pollen, dander, dust, shellfish, peanuts, chocolate, and medications such as penicillin. So this is like our anaphylactic reaction. So with it, it will have that allergic rhinitis. So type 1 immediate hypersensitivity response. Exposure to allergen triggers productions of immunoglobulin E, because remember E, epinephrine, so that's the one that's going to be released, and release of inflammatory mediators. So results in vasodilation, smooth muscle contractions of the bronchioles, and mucosis hypersecretion. Some of your symptoms include watery eyes, sneezing, rhinorrhea, and clear or white secretions. They'll have that pale nasal mucosa on assessment, and treatments can be things like antihistamine, intranasal corticosteroids, steroids, and decongestants. Anaphylaxis is when it goes to the extreme. So anaphylaxis is the severe life-threatening type 1 hypersensitivity reaction. It can be triggered within minutes by small doses of an allergen. So that's things like your bee sting allergy. Symptoms include hives, bronchoconstriction, laryngeal edema, tongue swelling, angioedema, and widespread vasodilations. So this is kind of the pathophysiology here. We've got immunoglobulins recognize and bind to the antigen, release of histamine, serotonin, and leukotrienes. Mast cells release more histamine and vasodilation occurs. Respiratory distress from fluid leaking into the alveoli. Fluid continues to leak from the blood vessels, blood pressure drops, and vascular shock. So with this, if you have a patient who develops anaphylactic reaction to anything from bee stings to penicillin, you want to make sure that they wear that medical alert bracelet and they carry an EpiPen with them. The degree of reaction is based on both the amount of allergen as well as the number of prior exposures. So for example, the reaction would be different if I was stung by one bee opposed to being stung by a horde of bees. So these are your anaphylaxis treatment: epinephrine, antihistamines, corticosteroids, and cardiac monitoring and blood pressure. So your type 2 cytotoxic hypersensitivity reaction is a delayed reaction. So what happens with these is immunoglobulins target cells coated with antigen, antibody-mediated cell destruction, and phagocytosis occurs. Characterized by formation of immunoglobulin G or immunoglobulin M antibodies against normal or foreign cells or tissues. So an example of this would be a transfusion reaction. So you get an incompatible donor, cells react with host immunoglobulins. So that would be like type B recipient has anti-A immunoglobulins, which you can kind of see on this picture here. It may be stimulated by endogenous, so inside the body antigens. So those are things like your autoimmune disorders. So things like Goodpasture syndrome, Hashimoto's thyroiditis, hemolytic anemia. It can also be stimulated by exogenous, outside the body antigens. So that could be things like foreign tissue cells or drug reactions. Now, if a patient has a history of type 2 cytotoxic hypersensitivity reaction, for them, they will not receive another dose of that medication. Like if they've got an allergy to hydrolysine, penicillin, or whatever will have you, then if they have this and they've got a history where they developed this hemolytic anemia, where their body's basically attacking itself and destroying itself, you will not give any doses of that medication because it puts them way at risk, especially if they have that hemolytic anemia. So that's why it's important to ask the patient what kind of reaction they had when it came to their drug reaction, because depending on the type of drug reaction they had, then you're just not going to give it at all. Your type 3 immune complex disorder or your delayed disorder. Antigen and immunocomplex circulates in the bloodstream and is deposited into the tissues, and it can cause organ dysfunction. So these are things like your lupus and your rheumatoid arthritis. Antigen may not be identifiable. And then we've got our lovely type 4 delayed hypersensitivity reaction. So the onset for this one is delayed allergic reaction. T lymphocytes that are sensitive to the antigen do not attack the antigen until days after the exposure. So these ones can be a lot later. So these are things like our contact dermatitis, poison ivy, or reaction caused by chrome jewelry, transplant reaction. Your TB test reaction develops after 48 hours if previous exposure, and your latex allergy. So going back, your first one is that hypersensitivity. It's going to be immediate. So that's basically, I got stung by a bee and now I'm going into anaphylactic shock. Your type 2 is a little bit delayed, but that's the one that's going to cause things of that hemolytic anemia, where, now it's attacking, what's it called? It's attacking self, basically. And then 3 is another delayed. That's more looking at things like your rheumatoid arthritis. And then 4 is another delayed one. And this is like our skin reactions. So your latex allergy is an interesting allergy because it can be, what's it called? It can be anything from a type 1 to a type 4, depending on the severity. So latex allergies are a very serious thing. So you can have like a type 1 where they'll go into anaphylactic shock, or it can be a type 4 where all of a sudden they will have something like a, what's it called? Skin irritation. So allergic reaction to natural rubber proteins. Around half of the patients with a latex allergy will also have a reaction to bananas, kiwis, avocados, strawberries, and tomatoes. It's implemented by rhinitis, conjunctivitis, contact dermatitis, asthma, anaphylaxis, or even getting hives. Prevalence has been decreasing due to the use of non-latex gloves, and 8 to 17% of healthcare workers are affected. So your autoimmune disorders are genetically linked. So it's one of those things where it comes back to your genetics. It's not like it's one that you can develop, you just have it and then you have to deal with it. T cells or immunoglobulins cannot make a distinction between self and non-self. Body forms antibodies against itself and cause organ dysfunction. So local example, D cells attack myelin in multiple sclerosis. Systematic example, immunoglobulins are developed against the body's DNA, cell membranes, and blood cells in lupus. So, like I said, your body forms antibodies to an antigen, as well as antibodies to body tissue mistaken for an antigen. So they might have similar amino acid sequences. So in rheumatic heart disease, the body forms antibodies against Staphylococcus organisms and also reacts with heart valves. So these are, just to kind of get you to kind of get this, is all these autoimmunes are genetically linked. So it's not like you can just suddenly develop it. It's just something within your body. All right, as always, if there's any questions, please let me know. Thank you.